Let's hear from Shreesh. I'm sure there's something so common and will be relevant to a lot of comprehensive ophthalmologists who are watching this. On to you, Shreesh.
Good evening. At the outset, I would like to thank Dr. Chitra. And my talk is vernal keratoconjunctivitis management. The step ladder approach is a continuation of the previous talk by Vinay. So we all know this vernal keratoconjunctivitis is an ocular allergy that is common in the pediatric age group, and it's often chronic, severe, and non-responsive to the available treatment options. And management of these children is difficult and often a dilemma for the practitioner. And there is a need to simplify and standardize this management. So the grading system, to achieve this goal, we require a grading system to judge the severity of inflammation and an algorithm to select the appropriate treatment medications. So limitations to the current management strategies are the lack of well-defined management guidelines. The choice of medications may vary greatly for the same severity of the disease from physician to physician. And this is often because of a lack of grading system to gauge and classify the severity of these VKC patients and the standard guidelines to suggest the most appropriate and safe therapy. So inadequate counseling and unrealistic expectations often result in overuse, misuse, or self-use of steroids, and it is not uncommon to see these patients with steroid-related complications such as loss of vision and while under medication. And persistent inflammation can also cause vision loss due to corneal scarring and stem cell damage. A delicate balance between the use of medications and side effects of these medications to be tailored to restrict tissue damage and also avoid medication-related complications. So the clinical grading system, it is usually possible to classify the disease severity into mild, moderate, and with intermittent frequency, moderate with chronic disease, severe and blinding subtypes. Patients may have findings that do not fall into the same severity. In these cases, the corneal findings are given more importance over conjunctival findings. For example, a patient having a large papillae but no corneal or limbal involvement may still be classified for treatment purpose as a mild disease because of the papillae may be inactive and not causing any corneal erosions. So the grading system is done in both the eyes independently. So the periodicity of the disease, again, it's an important parameter to be taken into consideration while planning the treatment. Child who has 2 or 3 episodes per year may be safely given a short course of steroid, mild steroids, and intermediate disease periodicity is defined as inflammation-free intervals of more than 2 to 3 months. This would mean a maximum of 3 to 4 episodes per year. And the chronic disease periodicity is defined as inflammation-free interval for less than 1 month duration, during which the patient is off medications. So this would mean that the patient has continuous ongoing inflammation, which possibly recurs on attempting to stop or taper the steroids. So the algorithm, the treatment algorithm, it aims to provide the safest possible way to control allergic inflammation based on the severity and periodicity. So this means that we use less potent medications in mild diseases and switch to more potent medications for severe disease. Treatment and natural fluctuations will alter the grade of the disease, and it will necessitate alterations in the therapy also. So typically, as the allergy waxes and wanes, so the severity grading will change, and accordingly, the treatment is also tailored. Coming to the mild disease, the patients will be symptomatic. They will have redness, itching, and all. And on examination, they have congestion and fine velvety papillae, but no corneal involvement. They should be treated with allergen avoidance, A, lubricants, L, and antihistamines, H, and mast cell stabilizers, M. And when there is no corneal involvement and if the inflammation is not very severe, you should avoid steroids. So the moderate disease, when there is corneal involvement in the form of fine punctate erosions, Horner Trantas spots with the focal limbal inflammation or thickening of limbus less than 6 clock hours or less than 180 degrees. They are classified as moderate disease, and patients can have intermittent or chronic symptoms. The treatment of these patients with moderate disease, they require add-on therapy in addition to ALHM, avoidance of allergen, lubricants, and antihistaminics, and mast cell stabilizing agents. Along with this, intermittent short pulses of steroids should be given in these patients. The soft steroids like loteprednol can be given to tackle the recurrences. And in chronic diseases, long-term continuous therapy with the topical cyclosporin or tacrolimus 0.03% is initiated. And for persistent inflammation, low-frequency mild steroids once in a day or once alternate days can be added intermittently. Coming to severe disease, what do you call it as severe disease? Patients with large active cobblestones, coarse erosions or keratitis, macro erosions, and severe limbal inflammation of more than 6 clock hours or more than 180 degrees. And those patients who are having evidence of limbal deficiency in the form of spanners or post-inflammatory scarring, these are considered as severe cases. And the treatment is again, they require that to be treated initially with the pulse or pulse of potent steroids along with the ALHM, and then maintained with the chronic use of cyclosporin or tacrolimus. Patients can require an additional maintenance therapy with low frequency topical steroids, typically once or alternate days. So coming to the next type, that is the blinding disease. Patients with extremely active large cobblestones, active shield ulcers, and severe annular limbal inflammation, limbal stem cell deficiency manifesting as extensive conjunctivalization, and limbal thickening, scarring, and extensive corneal scarring are considered as blinding conditions. And these patients has to be treated vigorously. These patients need continuous use of potent steroids in addition to ALHM. Cyclosporin and tacrolimus ointment can be used in combination, and these patients need to be more closely monitored for complications such as infection, cataract, and glaucoma. And they may also need supratarsal steroids and debridement of or superficial keratectomy for shield ulcers. Systemic steroids may be needed for very refractory inflammation or refractory cases. Omalizumab or oral cyclosporin therapy and intravenous immunoglobulins have also been reported to be effective in these blinding patients or blinding conditions, especially if they are repeatedly requiring systemic steroid use. So the conclusion here is there is a need for a better understanding and management of allergic eye disease. Grading of the severity of disease and periodicity of the disease can be very useful for deciding the appropriate line of management. Topical cyclosporin in higher concentrations and tacrolimus ointment are useful steroid-sparing agents and will help to safely control patients with moderate to severe allergy. The step-ladder approach is a novel way of managing these difficult cases in a day-to-day practice. Thank you.
Thank you very much, Dr. Shreesh and Dr. Vinay. We definitely got to understand a lot more about the systematic management here. I have a question to Dr. Merle and Dr. Revati. Um, these are the patients who are could have keratoconus too. So when would you think of doing a cross-linking in these eyes? And would it be more often a transepithelial cross-linking? And what would be a cover of medications which you have to give to these patients? Dr. Merle, are you there?
Yeah.
Yes.
Yeah, so I think what's very important is to have allergy under control before we actually cross-link. We don't want these kids rubbing their eyes after cross-linking them. And so it's important to have a control of allergy, and we use everything. So we, hit them with antihistaminics, preferably what I found that works is Comalfort along with tacrolimus, along with a pulse dose of topical steroids. And then we observe them for about a month and a half, and then proceed with cross-linking. Not too happy with transepithelial cross-linking, so we do epi-off. In those borderline cases, obviously we'll use hypotonic riboflavin. I haven't had much experience with bandaged contact lenses soaked in riboflavin, but maybe Praveen or any of the others could enlighten the group on what their experiences have been. But what's definitely a no-no is eye rubbing after cross-linking, because that would reverse the effects of whatever we've tried to achieve.
And the post-op.
Yes, sorry. Yeah.
No, carry on.
No, if I can just share our experience. We had done a thesis actually on VKC and in fact on pediatric keratoconus. We had about 114 children, out of which 62 had VKC. And the eyes which were cross-linked in cases of keratoconus following VKC, to stabilize their keratoconic corneas, it took a little longer, and also all of them had to be actually treated first with the anti-inflammatory therapy, so that, like Merle very rightly pointed out, their inflammation has to be absolutely quiet. The eye has to be absolutely quiet, and they cannot be inflamed, and they cannot be hot before you take them for cross-linking. In our experience also, I think transepithelial cross-linking is something that people are not doing now. Contact lens assisted cross-linking is only about 40% efficacious. So I feel that also will not, help in this. And the only thing that we did was conventional cross-linking as well as accelerated cross-linking. We've not analyzed that yet, but I feel that after accelerated collagen cross-linking, the chances of retreatment are more as compared to after conventional cross-linking in children, at least in this cohort. So I think that is something which really needs to be looked at into future.
Dr. Revati?
Our view is a little, our experience in pediatric cases, accelerated, we found it's equally effective as the conventional one, but we do only that 9-10 minutes one, not the super fast one. And of course, it is equally important to follow them very closely in the post-op period also. Since we are going for only epi-off, and of course, they will be strictly controlled with steroids and other immunosuppressives. The chance for infection is also more in these cases, and also healing problem, epithelial healing problem. So these cases have to be closely followed up post-operatively also, but we can't wean them off steroid immediately, but closely follow up with maybe antibiotic, epithelial-friendly antibiotic coverage. But our experience, Namrata, is accelerated is almost equally effective as the.
I'm talking about particularly these children who have VKC. In those we had to, those children are coming back more for redos as compared to those where it is not with VKC, when you compare our accelerated results with conventional results. So it's a smaller cohort that I'm talking.
Dr. Praveen?
Can I come in?
Yeah.
Dr.
Yes.
Chitra, can I? Yeah.
Yes.
So we have seen 4 cases. We have done we have published an article on Women Journal. This is on sterile and infective keratitis following CXL. It's a large series, around 968 patients we studied, and 10 patients had sterile and infective keratitis, of which 7 cases had sterile keratitis and 3 infective. And out of these 10 cases, 4 were having VKC, the active cases. And so 2 in each group, that is infective group, 2 cases out of 3. And sterile cases out of 7, 2 cases had VKC history. So that is one important point. Second one is like I have done repeat CXL in 2 cases in patients with the VKC, and repeat DALC in DALC after CXL in 2 cases. So I think we should be careful in these cases. The inflammation controlling the inflammation is very important in these patients.
Dr. Praveen?
Chitra, can I just come in here? One small thing.
Yes.
So what Dr. Shirish was talking about, in fact, if you look at the entire literature of microbial keratitis following cross-linking, majority of them, 60% or more of them across the literature, including Dr. Namrata's cases also would be there. Atopy is more correlated in these cases rather than just VKC. So atopic keratoconjunctivitis is primarily culprit in these microbial keratitis, and I wouldn't say culprit, but association-wise, there is a quite significant association with atopy and post cross-linking keratitis. So in cases of atopy, when we are doing cross-linking, I think we should be more careful.
Dr. Praveen?
No, I think, amazing discussion about the cross-linking and the associated keratoconus and also the complications as well. But I think of the really interesting points that both Dr. Vinay and Shreesh spoke about, the ability to be able to distinguish what is limited to only the eyes versus something that is part of a systemic phenomena also seems to have a large bearing on your treatment and how you will manage that patient as well, right? Because like Vinay said, VKC tends to burn out at a particular age, but then there are certain adults as well where you tend to have intractable allergies. So obviously the way you manage them and the way you deal with them is going to be different as well. So do you have any tips, both of you, on differentiating these two groups of patients and how you will approach them, especially if somebody has a lot of atopy as well?
I was just wondering, to add to that, would you do a systemic skin allergy test for these adult VKC patients specifically?
Exactly. I mean, very good question, because if you look around for people who are good allergy specialists, you won't find them. And I've looked, and maybe a couple in big cities, but they're not very common at all.
Yeah. Even our dermatology department, when we send them, are not able to pinpoint an allergen, although they have a whole battery of tests and they do all of it, but they are not able to pinpoint to a particular allergen, because I feel that there are that's what their this thing is, that there are so many allergens, it is so difficult to find which one is actually causing it. But I think that has a limited, I'm not saying maybe it has a great value, but to us, the availability of that is really not too much.
I think what Praveen says, it's actually quite interesting part that in treatment of allergic eye disease, we are not treating the root cause. We are just treating the effect by giving steroid, antihistaminic, mast cell stabilizer, and hoping that it's after some time, as Vinay said, that body will get used to it and then you will outgrow the allergy. But we are not treating, in any of our cases, we are not treating the root cause. And if we want to treat the root cause, if we want to get rid of allergy, we have to identify root cause. And nowadays, with all these allergy specialists giving those sublingual immune therapies and subcutaneous immune therapies, the outcomes are pretty decent. So I think that field needs to evolve a little bit better, and we should be communicating with them much more, even irrespective whether it's purely ocular allergy. I mean, the treatment has to have something which where we treat the root cause rather than the effect.
Can I add a point here?
Yes.
To whatever Himanshu said, of my patient cohort, I mean, I generally send them for an evaluation with an allergist, but then getting a positive outcome is very rare. Okay, the reason why I send them is because in the very few which, they could detect something where they could give the sublingual immunotherapy, the results have been fantastic. But the percentage of the so-called VKC patients coming who really do, have something like that is very few, very few.
So
I
which
guess
of
when I
these
feel
cases
those
are
few deserve that treatment when it's possible. So those few, at
Exactly.
least if they can be picked up and treated for the root cause, I think it's worth it still.
Correct.
Which of these cases are more likely to move on to limbal stem cell deficiency? What could you be doing as a prolonged treatment in some of these patients so that that take-home message that you prevent yourself to going to such a worst-case scenarios? Anybody?
Limbal stem cell deficiency, not all of them will proceed on to limbal stem cell deficiency. Only very few cases would, and those who've had, recurrent episodes of ectopic keratoconjunctivitis or vernal keratoconjunctivitis might have it, but not very many of them would go into that. And important thing is we are treating them symptomatically, but yes, I completely agree. The few ones that you are able to pinpoint not only respond well from the ocular point of view, but also from the systemic point of view, because their entire thing only, would be addressed rather than just the eye.
I think this topic could itself be one full webinar. There's so much to discuss and it's so common. But we